I am Dr. Renuka, Professor of Nephrology in St. John's Medical College, Bangalore. I'll be talking to you about basics of understanding edema. Before I really talk about edema, I just want to brief you about the anatomy and physiology. 1/3 of the body water is extracellular and 2/3 is intracellular. In this intracellular space also 25% is the plasma volume and remaining is the interstitial space. What is edema? Edema is defined as clinically apparent fluid in the interstitial compartment. And this, whenever there is a overt edema, it can be classified into two types, pitting and non-pitting Piddle edema. What is pitting Piddle edema? When you press on the tissue for some time, there occurs an indentation, and this is called pitting edema. And in non-pitting edema, even if you press, there will not be any indentation, as you see in this picture. Now, to come to the basic, what causes this what causes this edema? Interstitial fluid, liquid space, is dependent upon the hydrostatic force, osmotic force, as well as the lymphatic drainage. So, in fact, the basic edema, when it occurs, it depends on four factors: hydrostatic pressure, osmotic pressure, and the lymphatic drainage and the capillary permeability. These are the four factors which are very important in regulation of interstitial fluid causing edema. As you see in this picture, whenever there is increased osmotic pressure, whenever the normal osmotic pressure, fluid comes into the interstitial space, goes into the vascular space, and during hydrostatic pressure, it comes into the interstitial space. Whenever there is an hypoalbuminemia, there is decreased osmotic pressure and more fluid comes into the interstitial space, causing edema. Now, whenever there is an increased capillary permeability, which occurs in the local causes like cellulitis, in systemic causes like allergic reaction. Increased hydrostatic pressure, its local causes is compartment syndrome and chronic venous insufficiency. And in systemic causes, we have renal failure, congestive cardiac failure, anemia, pregnancy, etc. Whenever there is a decreased oncotic pressure, as occurs in protein deficient state like chronic liver disease, nephrotic syndrome, protein losing enteropathy, in these cases there is decreased osmotic pressure. Lymphatic edema is a poor drainage of the interstitial fluid as a result of lymphatic blockage. It can be congenital or acquired. So, whenever you have an edema, we have to have a practical approach. We should know whether the edema is unilateral or bilateral. If it is unilateral, we should think of the local causes first. And if it is a bilateral edema, then we'll have to look for the systemic causes, as in chronic renal failure or in heart failure, congestive cardiac failure, chronic liver disease, etc. So, we classify it into unilateral, bilateral, and then decide on the causes. What should be the causes? The common types of edema, is a peripheral edema. There can be cerebral edema, pulmonary edema, and macular edema. So, we are concerned more about the peripheral edema, which will be dealing more in detail now. Macular edema is something which involves the macula and it occurs in multiple causes. I am not going to go in the details of it. Pulmonary edema is another life-threatening condition in which the fluid accumulates in the lung, resulting in hypoxia. That is, the lungs do not expand, it becomes a solid mass and results in hypoxia. And this is a life-threatening condition. It can occur in variety of conditions like congestive cardiac failure, renal failure, etc. Cerebral edema, there occurs edema of the brain tissue. It also occurs in several conditions, which I am not going to go in detail. It causes confusion and altered mental status. Now, what are the causes of peripheral edema? Local causes are venous insufficiency, lymphedema. Then there can be systemic causes like in renal failure as well as in the cases of chronic liver disease. This is an exhaustive list of causes of edema. First is renal disease, cardiovascular disease like congestive cardiac failure, heart failure. Then there comes hepatic cirrhosis. Then there is interstitial disease like diarrhea causing malabsorption, causing protein losing enteropathy, endocrine causes like hypothyroidism, then vascular causes venous thrombosis, and diseases of the lymphatic system, allergic diseases, and idiopathic edema, in which some and side effects of certain medication can also cause edema. Now, edema in patients with kidney disease basically occurs because of two conditions. One is because of loss of protein in the urine, and other is because of the decrease in the GFR. The classical example of loss of protein in the urine is nephrotic syndrome, in which there occurs pedal edema, and there occurs pitting pedal edema in this condition, and sometimes there can be generalized edema, what we call as anasarca. Now, what causes this nephrotic edema? There are two theories behind it. One is underfill theory and another is overfill theory. In underfill theory, there occurs hypoalbuminemia because of protein loss in the urine, as a result of which there occurs decrease in the osmotic pressure, and as a result of which there occurs more fluid in the interstitial space, leading into causing the pedal edema. Another theory is overfill theory. In this, there occurs retention of sodium and water, as a result of which there occurs hypervolemia and increased release of ANP, leading to pedal edema in this condition. So these are the two basic theories, underfill theory and overfill theory. Now, how do you manage this pedal edema in nephrotic syndrome? The first and basic thing is you have to reduce your salt intake to 2 grams or 3 grams per day, reduce your fluid intake, and then try diuretics. Loop diuretics are the drug of choice. We generally use loop diuretics. In adults, we use 40 milligram to 80 milligram, and in children, we used around 1 to 3 milligram per kilogram body weight of furosemide. And once, if it is pedal edema decreases, it's a well and good. If it doesn't decrease, then we do a sequential blockade by using a thiazide diuretic, and thereby causing further reduction in edema. And this also doesn't help, then we have to use albumin infusion with diuretic. This is the basic principle of treating pedal edema in the patients with nephrotic syndrome. So loop diuretics, there are many loop diuretics available, butenamide, then furosemide and furosemide. We commonly use furosemide and furosemide. Furosemide bioavailability is more as compared to the furosemide. And if you see this pharmaceutical oral bioavailability of furosemide is very high as compared to that of furosemide. Now you see this cartoon, you can see the loop of Henle. When the loop of Henle, furosemide or furosemide acts on sodium potassium 2 chloride channel and blocks this and prevents the sodium absorption and thereby decreases the edema. But when you block the sodium potassium 2 chloride channel, there is excessive sodium in the lumen and it goes to the distal tubule, and in the distal tubule it gets absorbed through iliac channel. In order to prevent this, we generally give a sequential blockade by adding thiazide half an hour to 45 minutes before furosemide, so that it blocks the iliac channel, and once we block the sodium potassium 2 chloride channel, there is no further absorption from the distal tubule. Now, there are causes of diuretic resistance. I said as even if the maximum tolerable dose of furosemide or furosemide, sometimes the edema doesn't decrease. There is no significant weight loss, and that condition is known as diuretic resistance. It can occur because of many reasons, because there is a decrease. First is the oral bioavailability of these drugs, because of the gastrointestinal edema does not occur in nephrotic syndrome. Second thing is it decreases the diuretic entry into the tubular lumen, because furosemide and furosemide are protein bound and they reach the tubular lumen through the secretion. And if there is not enough protein, so that doesn't reach the tubular lumen. That is one of the cause of diuretic resistance. Increased distal sodium reabsorption. As I told you earlier, once we block the sodium potassium 2 chloride channel in the loop of Henle, the sodium gets absorbed through iliac channels in the distal tubule. In order to prevent this, we have to do the sequential blockade and use of concomitant drug which increases the edema, like non-steroidal anti-inflammatory drugs. Now, So in order to overcome this resistance, we have 2-3 methods. We have to give IV furosemide or IV torsemide to overcome this reaching the tubular lumen. Then we have to add a protein, like we have to give albumin infusion along with that. And sequential blockade is another method by which we can prevent this diuretic resistance. And sometimes we have to give furosemide or torsemide in infusion to prevent the breaking phenomena, which also is one of the conditions causing the diuretic resistance. So this is what is explained in the subsequent this thing. And the most important is the patient should restrict the salt and water, and this is one of the key to the management of any edematous state. Now, coming to the cause of pedal edema in a patient with chronic kidney disease, whenever there is a decrease GFR, what happens is there occurs either proteinuria or there occurs increased filtration of protein and macromolecule, again resulting in edema. And it also causes salt and sodium and water retention, resulting further in the edema. Similarly, in patients with congestive cardiac failure, what happens is there is, because of the heart not functioning properly, there is reduced arterial blood flow, as a result of which what happens, there are two systems, stimulation of sympathetic system, stimulation of RAS, which causes increased proximal tubular reabsorption of salt and water, leading to edema. Now what happens in cirrhosis? In cirrhosis, again there occurs a splanchnic vasodilatation, as a result of which there is a decreased arterial underfilling, decreased supply of blood to the kidney, as a result of which there occurs increased tubular absorption of sodium, resulting in edema. So these are the basic mechanism of edema in renal failure, heart failure, and in the liver failure. So there are certain drugs which cause pedal edema, like calcium channel blockers, beta blockers, methyl dopa can cause pedal edema, which all of us encounter in day-to-day practice, in clinical practice. Some hormones like corticosteroid, estrogens, and progesterone, they can cause pedal edema. Antidepressant drug, particularly MAO inhibitors, can cause pedal edema, and NSAID is a very big culprit in causing edema. And oral hypoglycemic drug like pioglitazone also causes pedal edema. So I would like to conclude by saying that pedal edema occurs in many diseases, and it is very important that we pinpoint what is the cause of this pedal edema before we actually treat the pedal edema. So for this, we have to take an extensive or good history is very important to pinpoint what is the cause, and then do appropriate investigation to find out what is the causing this, and then treat. And any condition, the loop diuretics are the backbone for treating pedal edema. And in the loop diuretic also we have various categories, and then we have to see the good bioavailability of and the good effectiveness of the loop diuretic, and we should use them appropriately. With this, we can manage the pedal edema. Thank you.